Welcome. Thanks for joining us for this Cochrane web seminar on understanding systematic reviews and meta-analyses in neonatal-perinatal medicine. Colleen, Caitlin, and I welcome you as part of the senior membership team and are very happy to include Bill McGuire from the Hull York Medical School as our new co-coordinating editor. Bill affectionately refers to himself now as the CoCo, and I must say this is a new and improved version of this old coordinating editor. Of course, with Bill moving up from the senior editorial team to co-coordinating editor, this has left room for Prakash Shah to step up and join our senior editorial team, and we welcome him as well. For our associate editors, John Dorling has joined this international crew who have been helping us to lead the Cochrane Neonatal Group and to allow for much more timely and insightful reviews for our authors. For today, we'll be joined in the flipped session by our guest discussants, my partners in evidence-based medicine, Daniel Ehret and Deirdre O'Reilly, both here at the University of Vermont College of Medicine. We'd like to thank our sponsors, the Vermont-Oxford Network, as well as the section on neonatal-perinatal medicine of the American Academy of Pediatrics. As an issue of disclosure, I am the president of the Vermont-Oxford Network and coordinating editor of Cochrane Neonatal, but have no other relevant financial issues to disclose. The point of today's webinar will be to understand the strengths and weaknesses of evidence that's provided from systematic reviews and meta-analyses and how they inform our practice in neonatal-perinatal medicine. In previous web seminars, we've discussed this pyramid of evidence on which we base our decision-making. And clearly at the top are randomized controlled trials and systematic reviews and meta-analyses. And we'd like to develop a greater understanding of how to interpret this high-level review. Towards that end, I would strongly recommend taking a look at a reference on understanding systematic reviews and meta-analysis that was published in the Archives of Diseases of Childhood in 2005. And much of today's web seminar will draw from information in that article. Let's start with a simple question about what is a systematic review and how is it different than the traditional reviews that we have read for decades. Traditionally, review articles have been narrative reviews, where experts in a particular field provide what is supposed to be a summary of evidence in that field. Narrative reviews, though common and useful in their own right, have been criticized because of a high risk of bias, and systematic reviews are preferred when we look at the sum of the literature. Systematic reviews apply scientific strategies in ways that limit bias to the assembly, critical appraisal, and synthesis of relevant studies that address a specific clinical question. While traditional review articles or narrative reviews can be useful when conducted properly, there is evidence that at many times they are of poor quality. The authors of narrative reviews often use informal, subjective methods to collect and interpret studies and tend to be selective in citing reports that reinforce their preconceived notions about what is necessary for treatment on that specific topic. They are rarely explicit about how they selected, assessed, or analyzed the studies that they are quoting in their narrative review, and clearly, therefore, may be more biased, and recommendations that are made in these reviews may in fact not be appropriate. If we think about it, it's tough for any expert to truly keep up with the field. If we just look at the wealth of information provided by high-order evidence, that is randomized controlled trials, in the past 10 years, we see that there are over 5,000 randomized controlled trials conducted in neonates. What we're talking about today is how you can perform a systematic overview, an overview that applies specific scientific research strategies to identify, appraise, and synthesize data from all relevant clinical studies. In many ways, the best way to think about these reviews is that you're conducting a study of studies, and that all of the same rigor that you would apply, for example, to a trial, you should apply to conducting this systematic overview. If possible, systematic overviews will contain quantitative analyses called meta-analyses, which are statistical methods to combine the results of similar randomized controlled trials to produce a typical estimate of the effect size. As I noted before, Meta-analyses demand the same methodologic quality expected from a randomized controlled trial. We have prospectively designed protocols regarding what studies will be included, what interventions will be included, what populations will be included. We have a comprehensive and explicit search strategy and strict inclusion criteria. Importantly, we define a priori the outcomes that will be included, and we apply standard statistical techniques. Why are these useful? Well, meta-analyses will increase the statistical power and therefore increase the precision of the estimate we derive from these analyses. But even when they don't show us specific important clinical differences, they allow us to explore the differences between study results. And they also create a structure in which we can incorporate any new evidence from other randomized trials. Let's go and discuss some of the rather basic methods behind doing the meta-analysis. Meta-analysis is a two-stage process. The first stage involves calculation of a measure of treatment effect, and importantly, calculation of the 95% confidence interval for each individual outcome from a study. The statistics that are usually used include the odds ratio, relative risk, and risk differences. And let's define some of them here. These are the ones that are commonly used by us at Cochrane Neonatal. So clearly, when you look at a study, you want to look at the event rates, both the event rate in the intervention or treatment group and the event rate in the control group. The ratio of those two event rates is your risk ratio or relative risk. So it's the ratio of the risk in the experimental group compared to the risk in the control group. So for example, if in both groups there's an identical event rate, 20% over 20%, that would be 1, and so your relative risk would be 1. Your risk difference is a simple statistic that we do all the time in our mind. If in your study there's a reduction in mortality from 20% in the control group to 10% in the treatment group, you would have a risk difference of minus 10%. And then there's a number that we really should use more often when we discuss the results of trials, and in particular, when we discuss the results of trials with families. And that's the number needed to treat, the number of persons who must be treated for one person to benefit, which is the reciprocal of the absolute value of the risk difference. So in that previous example, the 20% minus 10%, leading to a minus 10%, the reciprocal then would be 10 over 1. So it would say that for every 10 individuals we treated, there'd be one less adverse event in that group. Clearly a number that most parents and staff can relate to. Importantly, we also calculate the 95% confidence interval. The 95% confidence interval should contain the underlying effect in 95% of the occasions if the study was repeated again and again. You need to understand that these numbers don't mean necessarily the same issue. So for example, a relative risk and relative risk reduction measure the strength of the association, not the clinical importance. A large relative risk is evidence of a causal relationship. It's only when we look specifically at the risk difference do we see the evidence of an actual effective treatment. In the second stage of analysis, the overall treatment effect is calculated as a weighted average of the individual summary statistics. In meta-analysis, data from the individual studies are not simply combined as if they were from a single study. This is true when you do a multi-center study. You don't simply add up all the babies across all 10 centers in a multi-center study, but you weight them by centers. In a meta-analysis, the centers of a multi-center study are essentially the results of that individual study. Greater weights are given to the results from studies that provide more information because they are likely to be closer to the true effect we are trying to estimate. The weights are often the inverse of the variance of the treatment effect, which relates closely to sample size. The typical graph for displaying the results of a meta-analysis is called a forest plot, and we'll get to that later in today's discussion. Although systematic reviews occupy the highest position in the hierarchy of evidence on effectiveness of interventions, it would be unfair to assume that the study is valid simply because it was a systematic review. Just like in randomized controlled trials, one needs to take into account the validity of the trial methodology, the magnitude and precision of the effect, and the applicability of the results to your patient or population. I've always loved the title of this article from Steve Goodman, Have You Ever Met an Analysis You Didn't Like? And some people probably think that I haven't, but the fact is, it's quite clear there are some problems with meta-analysis. For one thing, sometimes there's only fair agreement between well-conducted, large clinical trials and the meta-analysis of the smaller trials looking at the same interventions in similar populations. Here's an example looking at the treatment of aspirin for the prevention of preeclampsia. And you can see the meta-analysis of studies shows a very strong result regarding reduction in the risk of preeclampsia. The single, large, well-conducted randomized controlled trial shows nowhere near as great an effect. The effect is in the same direction, but both the magnitude and the degree of the effect are much more muted. Why should that be the case? Well, there are a couple of obvious methodologic flaws that may contribute to this. One of which is publication bias, the tendency for investigators to preferentially submit studies with positive results, and the tendency for editors to choose positive studies for publication. And the other is heterogeneity, the variation in the direction or degrees of results between individual studies. And let's take a few examples of these problems in methodology. Here we have the issue of language bias, which can contribute to publication bias. I speak English, and obviously only poorly. I speak no other language. I read no other language. I'm fortunate that in today's world, much of the premier medical literature is published in English journals. If I'm a German investigator and I have a positive result, I would like to share it with the broadest audience, so I might go through the headache of writing up this research in English. If, in fact, I don't have a significant result, and I think it's questionable whether or not the journal article will be accepted for publication, I might not go through that hassle, and I would just write it up in German. And so, in fact, when it comes to German investigators, they will publish their positive results more in English and their negative results more in German, which means that for me, as a non-German speaker, I may never see their results. And if I'm doing a meta-analysis, I may never find those negative results to incorporate them. Now, heterogeneity is a very interesting issue. Inevitably, studies brought together in a systematic review will differ and will be heterogeneous. Any kind of variability among studies in a systematic review is heterogeneity. The most profound type of heterogeneity is the clinical heterogeneity, the variability in the participants, in the intervention, or the outcomes studied. This is something that the author of the review has to address prospectively and clearly. And in fact, you as readers or users of the meta-analysis may not agree with those decisions. But there's also the heterogeneity that we're unaware of, that is only picked up by statistical analysis that comes from probably differences in study design, risk of bias, or unknown biases. So one of the basic problems with systematic reviews is that they are reliant on the component RCTs and the methodological quality of those RCTs. If the randomized controlled trials aren't good and aren't methodologically sound, there's no way the systematic review can be. In terms of reporting reviews and the appropriate methodology, there have been some expert groups who have published very clear and extensive recommendations regarding how to report systematic reviews. So here we have the PRISMA statement. It's published in many sources. I'm quoting the source from the BMJ here for your reference. There are long lists of what an appropriate systematic review should include, ranging from how it should be titled, how the abstract should be constructed, what information is in the introduction, the methods that should be used, the results in the discussion, and even the funding. And I'm going to cherry pick what I think are some of the most important aspects of this and use one of our Cochrane reviews, the reviews on therapeutic hypothermia, to illustrate some of these points. So, for example, the review on cooling seeks to determine the effect of therapeutic hypothermia on death and long-term neurodevelopmental disability and to ascertain clinically important side effects in the newborn infants with HIE. So the first thing you have to understand is what really is the PICO question? What are the specifics of the population, the intervention, the comparison, the outcome, and the time frame that's being addressed? If we break the cooling review down, we see that the PICO might be structured as follows. In newborn infants with HIE, does therapeutic hypothermia, compared to conventional management, decrease the risk of death or long-term neurodevelopmental disability at 18 to 24 months of age? This may or may not be your question, and when we flip the classroom, we're going to explore this more about what other valid questions you might ask or what you might have expected from such a review. But this is the question they asked. Their next job is to search for the literature. Nowadays, searching databases is clearly something very familiar to all of you. This is a little bit of a self-discovery, but I'd like to share with you that I have a penchant for collecting mechanical banks. And if I go on eBay and I just check off banks, I'm going to be spending my lunch hour looking through 14,000 items. But with a little knowledge, I can refine that search. And if I'm just interested in cast iron banks, well, I can get that quickly down to 800 banks. But that still will take up more than my lunch hour. Even if I ask for mechanical banks, there are so many around, so many knockoffs, so many banks to go through. I couldn't make it through 300. But if I refine the search even further to a specific bank that was made in the 1950s, the Book of Knowledge Bank, voila, 14 items, I can look at them all, I can examine them, and so forth. Well, the search of the literature is not that different. There are so many items to search through, but we have come up with what we think are relatively sensitive and specific search strategies to look at the main bibliographic databases to try to ascertain where are those studies that we need to include in our systematic review. So looking here just from the year 2000 to 2019 for therapeutic hypothermia, we see that just a simple search of Medline yields over 14,000 items. But if we narrow it to newborns, we have 1/10 that amount. Still too many, even for a few days of searching. If we look just at clinical trials, we have 169 items, and now that's probably quite meaningful. And we could further reduce it by looking at randomized controlled trials and 127 items, but frankly, it's probably an unnecessary reduction from the 169, and we really could spend the day looking through all the clinical trials to see what should inhabit this systematic review. Once we identify multiple studies, if we think that they are sufficiently similar, we consider performing a meta-analysis on that data. As I noted before, there are certain typical clinically relevant statistics that we calculate. We don't rely just on issues like p-values, but we calculate issues like relative risk, risk difference, and the 95% confidence interval. At Cochrane Neonatal, we use a fixed effects model to combine the data, where we think it's reasonable to assume the studies are estimating the same underlying treatment effect. When we present the data, it's mostly done in the form of a forest plot. This plot shows at a glance the information from the individual studies that went into the meta-analysis, as well as an estimate of the overall results. And it also allows a visual assessment of the amount of variation between the included studies, so-called heterogeneity. Here's an example of the forest plot from the review of cooling for hypoxic ischemic encephalopathy, looking at death or major disability in survivors and looking at the relative risk. Here you can note that the line of identity is 1 because we're looking at relative risk. We could equally so look at risk difference, and we see that there are differences in the message we get regarding this outcome. Here the line of identity is 0, and importantly, we see in fact a greater clinical response when we look statistically at risk difference. Let's break down the forest plot because I'm sure for some of you, your eyes absolutely glaze over when you look at this. And let's go point by point because it's a rich source of information and it shouldn't scare you. I've tried to annotate this here, and I'll first draw your eyes to the studies that are on your left. Each individual study is listed there, and you could find the study of interest, and you can look at the results from that specific study, and in this case, find the risk ratio from an individual study. If you look over at the plot itself on the right, you can see how these risk ratios are plotted. The point estimate is the dot in the middle, and the size of that point is the weight that it contributes to the meta-analysis. The bar itself is the confidence interval, and you can see that in some of the smaller trials, the confidence interval includes the possibility of both being of benefit or potentially being of harm, though in this case, most of the studies are large enough that the confidence intervals are fairly refined, and most of them certainly trend to your left, suggesting just visually that there is an effect of hypothermia on death or major disability. Importantly, that little triangle at the bottom gives us the so-called typical estimate, sort of the gold of the meta-analysis. Here we see a typical estimate of 0.75, a 25% reduction in the relative risk, and a confidence interval that's relatively narrow and meaningful, ranging from 0.68 to 0.83. There is another little statistic there at the bottom to point out to you, and that is the I-squared statistic, which is a statistical measure of heterogeneity. The I-squared can show some of the unexpected inconsistency across studies, so even though we thought they were clinically groupable, the fact of the matter is there may be subtle issues that can be picked up statistically to say that they might not, in fact, really be measuring the same effects. There are some rough approximations for where the I-squared is important and needs to be addressed, and you'll see many different cut points recommended by different meta-analysts. These are the ones that are recommended by Cochrane Neonatal, and I think you can see that once you get to an I-squared of 50% or above, you may be dealing with substantial heterogeneity. Importantly, even after we look at the results from the typical estimate, there are many ways of interpreting it. Here's a nice cartoon that shows us the different ways that the confidence interval can be interpreted depending on where it lands. Importantly, you first have to have an idea of how much benefit you are seeking from the therapy. And so, if in fact you have a small benefit, such as the tight confidence interval in the middle there might be a benefit, but it might be trivial. The ones that are the far extremes at the top of the figure that is far to the right almost certainly is beneficial, and the one far to the left might be very harmful. But they're not all equivalent, and they all need careful thought. Once we have our estimate, we need to look at how valid we think that estimate is, and we do use the grade approach to assess the quality of the evidence. We'll be discussing about grade in much greater detail in the coming web seminars, but just to touch base on this, we consider evidence from randomized controlled trials to be high quality and only downgrade that evidence for serious limitations based on issues of bias, consistency, directness, precision, and publication bias. These factors all combine together to give us an idea of not only do we think that the measure is important, but we think that the studies that allowed us to make that assessment are valid. Importantly, healthcare professionals must always make judgments about the results of a study for their own patient population. And that means they have to understand whether or not the studies represent populations similar to the individuals they're going to treat, what the benefits and harms are, patient preferences, availability of therapies, and costs. So meta-analysis can be very useful in guiding our practice, in formulating research questions, and creating a context in which to view new evidence. But when we flip the classroom, Dr. Ehrhart and Dr. O'Reilly and myself will discuss further how you read and interpret this information and what some of the strong benefits and pitfalls are. Thank you, and please do join us when we flip the classroom on meta-analyses and systematic reviews.
Hello and welcome. Thank you for joining us for the live portion of today's Cochrane Neonatal webinar, Understanding Systematic Reviews and Meta-Analyses in Neonatal-Perinatal Medicine. And now I'm going to turn the webinar over to Dr. Saul.
Thanks so much, Colleen. I'd like to begin our flipped classroom with a somewhat sad thought. Arne Olson, our colleague, the professor emeritus from the University of Toronto, died last week. Arne was a wonderful colleague, mentor, and friend to many who will be on this call and many in the neonatal community. There was no one perhaps more thoughtful, more soft-spoken, more thorough in his thinking. He was the most agreeable man, and he could disagree with you in the most agreeable fashion. He was truly a great person. He contributed to Cochrane before it was Cochrane. He was a author in the famous book Effective Care in Pregnancy and Childbirth. He was the director of Cochrane Canada. He was a senior editor with us here at Cochrane Neonatal, and he'll be missed by many. So, on a brighter note, I join you here live with our two guest discussants, Dr. Daniel Ehrert and Deirdre O'Reilly. They are my partners in evidence-based medicine. They're also my partners in practice up at the University of Vermont Medical Center. And I have to say, you should all be so lucky to have people who you work with who are as committed to bringing the evidence to the bedside and committed to helping us today understanding and criticizing some of these issues in our flipped classroom. I'd like to thank our sponsors, Vermont Oxford Network, as well as the section on neonatal-perinatal medicine of the Academy of Pediatrics for helping us bring you these web seminars. As noted previously, I am the president of Vermont Oxford Network and coordinating editor of Cochrane Neonatal, and we'll be using data from Vaughan as well as reviews from Cochrane Neonatal, but I have no other relevant financial issues to discuss. And we're going to further our goal of understanding the strengths and weaknesses provided by systematic reviews and meta-analyses to inform our practice. Please do chat in your questions as we go along. We'll try to work them in, and hopefully you'll get to voice your opinions and thoughts in our Poll Anywhere questions. So to begin with, just to repeat, meta-analyses are very specific reviews, and although we value them at the highest position in our hierarchy of evidence, they need to be critically appraised just like you would a trial. We need to make sure that the methodology is valid. We need to understand and interpret the magnitude and precision of the treatment effects. We need to understand whether the results are truly important to our population. And I'd like to continue from the recorded version and use the cooling trial as a paradigm. I noted before the PICO question that the authors of the cooling trial attempted to use. And I'd like to ask you all about what you think the right question should be. So although they stated that in newborn infants with HIE, does therapeutic hypothermia compared to conventional management decrease the risk of death or long-term neurodevelopmental disability at 18 to 24 months of age, I would like to ask you, should this include infants with mild encephalopathy? Do you agree, disagree, or are uncertain? We'll let the poll run for a second, see if we can get some results. So far what I'm seeing is 100% disagreement, that it should not. There we go. Now we have two people answering, 50-50. The math is getting harder. Excellent. We'll keep the poll open for a few other seconds, and then I'll turn it over to our discussants to discuss the pros and cons. So, let's discuss. Is this the PICO question you would ask? There's no right or wrong, obviously. And what are the strengths and weaknesses of how you frame the question?
Well, I think now that we know the way we've implemented hypothermia, it would be wonderful to have this as part of the PICO question, but I think it would be a very different study. So it probably should be its own question in and of itself, which is challenging. I don't know, what do you think?
Yeah, no, I agree with Deirdre, and it looks like the majority of our responses. I answer disagree to this question, not because I think mild encephalopathy isn't important, but because it's its own question. As you talked about kind of the clinical heterogeneity, I think these really are two different populations. We think about the potential for death very differently, severe to mild encephalopathy, and the potential risks of the therapy itself.
So I'm uncertain. I'm in the 4%. We know what the trials did, and we know why the trials did it in terms of the effect on moderate to severe encephalopathy. But in some way, the question is more generalizable, and perhaps just subgroup analyses or more careful questions. As you point out, Danielle, not only the risks, which may be less in the mild population, but we might learn a great deal about safety and harms. So I'm uncertain. I think that for the first pass they did the right thing, but now when we confront the question, clearly we're all interested in the child with mild encephalopathy, and this review needs to be updated. All right, so let's address some issues of risk of bias. And let's go to an individual study, Sita Shankaran's study done with the NICHD on whole body hypothermia for neonates with hypoxic ischemic encephalopathy. And I won't make you read through the whole abstract, but I think most of you are aware. In this study, they randomized infants to a usual care group or whole body cooling to an esophageal temperature of 33.5 degrees centigrade for 72 hours, followed by rewarming. If you've ever seen a picture of this, this meant that the babies were on a cooling blanket, but also to prevent great variation in the cooling, and so that there was some servo control, they had a huge blanket hanging by the bedside. So I ask you, for the poll, this study adequately blinded? So while you're answering, let me just say that when we talk about biases, they're not the same as a mistake in methodology. And while we're answering this, most people feel that it wasn't adequately blinded. What do my colleagues think?
So I think this is a very tricky therapy to blind. I don't think you can blind the therapy, but what I did appreciate, and it isn't in that abstract itself, but the blinding of the neurodevelopmental assessment, which is the primary outcome, death or developmental outcomes. So that part was blinded by trained providers. So I think they probably did as best as they could to blind the outcome assessment.
So that's an extremely important point. In fact, although I did address sort of the study being blinded, when you judge the biases, it's really about the outcome measure being blinded. And within an individual study, you really could have a different assessment of the need for retreatment in an unblinded study, which might be highly subjective, versus the findings on the MRI or developmental findings in the clinic 2 years down the line. So I think that's very important. The other issue, though, is that even if you can't blind it, it is a deficiency. I think you're all aware that there was a difference in death in the two populations. And one of the first questions the investigators themselves asked is whether or not there was any difference in the withdrawal of care, whether there was any differences between the two groups, which there are not. But even in the best study where blinding is not possible, biases could theoretically occur. And so we have to accept that, even if it's just a function of the nature of disease, care, and the intervention. All right, let's move on. And let's talk a little bit about analyzing the forest plots. As I mentioned earlier, it tends to be something that I think for some people it's very off-putting. For one thing, when you project it in a slide, you could barely read it in the back of the room. For another thing, there's just lots and lots of information there, which frequently people don't really go into. So let's take a look at this type of figure and some of the strengths and weaknesses. And here again, we have the issue of death or major disability in survivors and relative risk. And what I'd like to ask here, and I don't know, I guess I'll have to go back to it, is whether or not you thought there was any meaningful statistical heterogeneity in this meta-analysis. And Andy, can I go back a slide so people are reading while they're answering?
Yes.
Okay. Oops.
Oops. But you can, yeah,
There,
okay.
Oops. No, I'm okay. There we go. This is what happens when you're live. All right. So far on the poll, most people do not think that there is meaningful statistical heterogeneity, but there's some that are uncertain, understandably, and some people who think that there is statistical heterogeneity. Thoughts?
Yeah, well, I mean, I think this question is an excellent one because it brings about the question of statistical versus clinical heterogeneity and what you're ultimately interested in. I would argue both, but here it's clear from the forest plot when I put my reading glasses on that you can see that the I-squared statistic does not show any significant statistical heterogeneity. But that doesn't tell us as much as we might like to know about the individual population and the studies themselves. So I think it depends on how you're using this and the way you want to interpret it for your own patient population.
Yep. So I agree. I mean, clearly the I-squared is 0.
Right.
And it's 0 in the overall where we combine the two subgroups, which frankly is the place that I would have thought we might introduce heterogeneity, namely using the cool cap versus using the whole blanket. And there are many other places where heterogeneity could be thought of. There are some very small pilot trials here. There are also trials from very different care environments. There's one larger trial from China. And so there are different techniques, similar populations across them, which of course is interesting and perhaps the core issue there. But the fact that there is no statistical heterogeneity doesn't tell us that there might not be differences that are important. And still, if you choose to cool a baby, you're going to have to dig down into the study and examine that clinical heterogeneity. Which technique am I using?
Right.
Which population am I treating, et cetera? But here, no statistical heterogeneity, but it doesn't answer the question about are these clinically different? They seem very similar, but a question that remains. So here's a slide just describing the cut points for heterogeneity, and you'll see it's different from the slide I originally showed you because Colleen Ovalman appropriately corrected me and said that, boundaries that cross over aren't that useful to people, and in fact Cochrane Neonatal has moved to more specific boundaries. And although, frankly, you'll read different ones, this is probably what we'll use in reviews and you should use in your own writing. All right, so let's talk a little bit about the other statistic, risk difference. And here is the forest plot that shows not the relative risk or the RR, but shows the risk difference, the absolute difference. And what you see there is a typical estimate that says there's a 15% difference in the rate of death or major disability in survivors, with a confidence interval that says it could be as much as a 20% decrease or as little as a 10% decrease. And so I'm going to ask you guys to perform some rather basic statistics on that. And I'll show you the poll, but then I'll go back to this for your calculation. So tell me, the number of infants needed to treat to prevent one infant from dying or having major disability based on this review is 3 infants, 6 infants, or 15 infants. And I'll go back to the figure there. We've got it. And you guys can take a second to look at that while you guys look at the calculations. So, most of you answered 6, and I will defer to my colleagues to tell you why you were mostly right.
Yes, and I agree with the majority of the answer of 6. You showed us that the absolute risk difference is 0.15. So in taking the inverse 1 over 0.15, we get the answer of 6. And Roger, I think, is the best about doing this math in his head and also doing the confidence interval and saying it could be as little as this or as much as this. And I agree with kind of the assessment that was in the first part of this session of how useful this is, both in talking amongst your team, but in explaining the results of this to your family, of how do we really talk about this therapy and its potential on the baby in front of you.
Yeah, I absolutely agree. I mean, I don't think, perhaps you in the audience know just how profound that is. We have very few therapies that prevent such a major outcome that only require 6 infants to accrue the benefit. And so I think that's powerful all around about motivating you. And of course, there are other examples. For example, pulmonary hemorrhage is a complication of surfactant therapy. And if you're talking to a parent, you would have to say it doubles the risk of having pulmonary hemorrhage. And if I was a parent, I would say, well, don't ever use it in my child. But the fact is, it went from 2% to 1%, from 1% to 2%, suggesting you have to treat 100 babies before you would see this rare but serious event. And it's particularly good when there are competing risks, so there are benefits as well as those risks. Example probably being the neoprom trials, where there's more death associated with the lower saturation limits, but more retinopathy. And if you as a staff, or certainly as a parent, are weighing this, you would need to know, one less death for every 33 infants, but 3 less cases of retinopathy. But let's move on and discuss generalizability. So we've been using hypoxic ischemic encephalopathy and cooling as our paradigm. And not to get into a talk that really focuses just on that, but I think it's important to understand the underlying thoughts around the pathophysiology of hypoxic ischemic encephalopathy. We all know that there is an acute injury. We all know that there is cell death that follows that, a period of so-called necrosis. And then sometime after the injury, there's a secondary response with reperfusion, and we think of the cell death there being apoptosis. Because of this, we think perhaps there's a window of opportunity for treatment that's fairly standard within the first 6 hours, and animal models support this. We have a strong basic science construct to support the idea that this should be a useful therapy in HIE. So I ask you, based on the results of the meta-analysis and based on your understanding of the effects of therapeutic hypothermia, should this be given to infants with moderate or severe encephalopathy worldwide? So very interesting distribution of responses. And I do want to state a caveat that I firmly believe that this issue of equity and of giving these therapies that may be beneficial to children in all various healthcare settings and economic settings is in general a principle that we all want to embrace. And I see that about 60% of those responding do. Can I defer to you guys about your thoughts on this?
Sure. So I answered this question uncertain, and I agree. I think you really do have to think about how do we best care for babies with moderate to severe encephalopathy worldwide, and how does the implementation scientist in me think about this question? And thinking about kind of the patient population and the clinical heterogeneity, I think, when we talk about worldwide, there's vastly different, baseline rates of early onset sepsis, our certainty of the gestational age of infants that are being treated, the healthcare delivery system in general. And I think we have to be quite thoughtful about that and how do we apply the knowledge from these very much a high income country studies to a very different population in a clinical setting. So I think it's a great question that deserves further study. So I'm uncertain how those original studies would translate to very different settings. So I think that's a wonderful opportunity for future research.
Yeah, I agree completely. I think and everyone who knows me knows I agree with cooling a lot of babies, but I think that there might be some unforeseen adverse events, and we want to be absolutely certain that this remains a safe therapy and that you're benefiting the patient population that it's intended for.
It is such an interesting question, though, because everything you read about HIE says that there's an order of magnitude more of this in less countries. Economically developed situations, and so it's a pressing need. And we all know that although most of the studies were not done with this technique, some successful studies were done with very low-tech issues, like ice bags and passive
fans.
cooling and fans, exactly. And so The idea that I might foolishly have had was we should just get busy teaching centers and having centers look about identification and possible treatment. But what we find out is the reports aren't so promising. I refer you back to this letter to the Lancet from Nikki Robertson and colleagues regarding a pilot randomized controlled trial. It was a feasibility trial, so they basically agreed with you, Danielle. They didn't say just do it. They said this needs testing. And they stopped relatively quickly because they had a huge discrepancy in mortality, with 7 infants in the therapeutic group dying compared to 1 in the standard care group. And this led other investigators to do a meta-analysis that separately looked at low and middle income countries. Now, I think I'm going to share this meta-analysis with you. To me, this is a subgroup of the main analysis and should not stand on its own because we can cherry pick all sorts of other types of things and publish them separately. But if we think of this as a subgroup of the studies, it's a very effective presentation. They identified 7 trials with 567 infants. And ultimately, that's a small sample size, but we know this is a relatively rare problem and hard to organize. But what they found was they didn't see the impressive results that are reported in the overall meta-analysis. They still do trend, as you can see from the forest plot, to the left. And the Robertson trial there is starred because it's the only one that's conducted in a truly low-income setting. But the others that were done in middle-income countries really are somewhat smaller and less impressive, and they suggest that we're not yet certain about the harms or the benefits in this clinical context, and it deserves, I would agree with you, further trial. So this brings out the point again about the applicability and the generalizability and the fact that we don't always know as we try to apply data from other settings. One question that came up is from the chat is someone wrote in that they were surprised. Just like many other standards of care, this needs to be a standard of care. The governments will then work for supporting this. What is the standard of the World Health Organization about this? And it is a great and important question. But sometimes, and Danielle, you know more of this than I, sometimes there's a disconnect between the recommendations that are made and how much evidence we have.
Yes, absolutely. And I agree about, having standards of care. I think currently there hasn't yet been a standard for treatment for therapeutic hypothermia, really a focus on preventing hypoxic ischemic encephalopathy and having neonatal nursing as a profession. And I agree wholly in that and advocating for, having the best possible care for babies worldwide in general will lead to improving neonatal care. And so I agree with the comment in overall.
Yep. One other chat in regards to taking a Bayesian approach to this. In some ways, this puts the lie to that we don't understand the prior probability.
Right.
So it's difficult. All right, let's end with this question for all of you. And this has to do with vitamin A supplementation. And first, I'm going to ask you to answer the quiz before I even talk about any information and ask whether or not you routinely use vitamin A for the purposes of decreasing the risk of BPD in at-risk preterm infants in your unit. We'll give this a minute. And although the majority are saying no, there is a significant minority that are saying yes. So let me turn it over to you guys for your thoughts.
I have the benefit of being exposed to places that both use this routinely, but now working where we are currently is not. Some of that had to do with the fact that it was off of the market. There was a shortage for quite a while. And then it wasn't readopted. And it's really interesting to think about the reasons why it was not readopted. So we do not use it routinely at UVM.
We did at one point, and we abandoned it when it became too hard, and I think sort of gave up with a type of frustration. And I think I understand the motivations, but I'm not sure. And here, taking a look at the meta-analysis from Brian Darlow and colleagues, we see that there is a reduction of the risk of 13% in chronic lung disease at 36 weeks postmenstrual age in infants who received intramuscular vitamin A. But here, I think the issue is one of the confidence interval that ranges from a possible 23% reduction to just a tiny 1% reduction. And when we look at this in terms of death or chronic lung disease, similarly, we really don't see a major reduction. We don't have confidence in the reduction, which, given the fact that it was a drug that was hard to get, that there isn't a nurse in the world who liked giving so many IM injections to a tiny baby, I think the question there is whether it's worthwhile. And this brings me to a point that I made in the earlier taped version, but I'd like to reiterate with a slightly different figure, which is that in our own minds, we not just have a statistical line of no effect, but we have a picture of what constitutes a meaningful effect. Certainly the whole literature on so-called non-inferiority relies on us picking such a line, but frankly, we do it for all studies. And in this case, it really looks more like those studies that are sort of grouped in the middle there, statistically significant difference, but not important to patients. This becomes a matter of values and probably something we probably should recruit more parents in discussing. But I think that that's the reason why we at UVMMC and the majority of centers answering said that they didn't use it. So I'm going to close up here. First, thank my guests. Always a pleasure to have them in studio with us. And just reiterate that this is still a very useful process, despite some of the criticism I've shared with you. It guides our practice. It helps us formulate future research questions. And when new trials come down the pike, it allows us a context in which to review new evidence. So again, many thanks. I ask you to consider joining us in December. And I'll turn this back over to Colleen to close it out. Thank you.
Thank you, Roger, and thank you, Danielle and Deirdre, for joining us today. Our next session will be December 2nd, and for this session, we will not be using the flipped classroom approach. Instead, we will have a whole session that will begin at noon and run for an hour and be on feeding the preterm infant. We'll switch back to this evidence-based classroom and our in the new year, and our first session for that will be on making grade recommendations. We hope to see you all in the future. We will have the CME survey is now active, and we'll also send a link out to all of you for that, and you can always email us if you have any questions. Thank you all for joining us today.